Well, thank you guys very much for this invitation here today. Professor Caldwell and I are very excited to speak with you guys in regards to our article in the inaugural issue of your journal. We hope it is very successful, and we hope our audience today enjoys this discussion. So to answer your question about the heterogeneity of NAFLD, or non-alcoholic fatty liver disease, what we know is that it is a very heterogeneous disease, meaning that the presentation can be varied among different people. And one of the things that makes it somewhat difficult sometimes to diagnose can just be that there are a lot of different variations, both in the severity and sort of clinical presentation of it. What we know is that it tends to be a disease associated with patients that have the metabolic syndrome, so obesity, diabetes, hypertension, hyperlipidemia. But that's not all exclusive. There are many people that have what we call lean NASH or lean NAFLD, where their body mass index may be actually normal or only slightly overweight. And that can lead to its own diagnostic challenges. And then I think in terms of one of the biggest things clinicians sometimes struggle with is sort of defining actually how severe is the disease in patients. And so NAFLD can have a whole spectrum ranging from patients with just simple steatosis or just fat in the liver, ranging all the way to decompensated cirrhosis. And I think one of the things a lot of referrals often ask us as clinicians and hepatologists specifically is sort of, how do we stage this patient and how do we figure out how much fibrosis they have? Because ultimately that's what determines whether this patient is at risk to progress to either advanced fibrosis or cirrhosis.
Yeah, I think the term heterogeneity just gives you the idea that there is a spectrum. If you define NAFLD or non-alcoholic fatty liver as a particular amount of triglyceride excess in the liver, usually it's over 5 to 10% by weight, and but then that within NAFLD or NAFLD, you'll have NASH. And then you have many patients with non-NASH fatty liver. And NASH is the concerning one, but there's heterogeneity in that respect. And then there's heterogeneity in comorbidities such as diabetes, as Brian mentioned, diabetes, obesity, dyslipidemia, hypertension. One thread that's almost always present, even in patients with lean NASH, though, is insulin resistance. And we don't often measure that. And in sort of the way I think of it, insulin resistance is there, and it may be evident as overt diabetes depending on the health of the pancreas. So if the pancreas can keep up with insulin production, the patient doesn't appear overtly diabetic. If not, then they develop diabetes.
Yeah, I think that's an important point, in that I think when we're sort of seeing these patients, we need to sort of identify who is either at risk or has already developed NASH, because as Professor Caldwell said, that's sort of what patients are really at high risk to have long-term complications. And one of the reasons it's also important is because with NAFLD being so common, with it being seen in 25 to 30% of the population worldwide, there's been a lot of interest in the pharmaceutical industry for therapies targeting both steatosis and, more importantly, antifibrotic agents. And so sort of identifying patients that may benefit from either undergoing trials or other therapies that may have some benefit, such as things like vitamin E or pioglitazone. It's important to sort of understand where the patient is on that spectrum to see if they may benefit from therapies, both proven or experimental. Yeah, and so I think what we know is that, as we just talked about, NAFLD is a very heterogeneous disease, and I think over the past several years we sort of started to understand some of the genetic predispositions to it. Many people are familiar with one of the gene polymorphisms, PNPLA3, which is probably best studied. And essentially has to do with when people get mutations in this, their liver tends to have an increase in the amount of stored triglycerides in it, leading to that steatosis. This is something done often in a research setting, and it has not yet made it applicable to routine clinical practice, because we just don't know yet really how to best utilize this in the patient population. And so far, we haven't directly studied it in relation to which, are there certain therapies that this patients with this polymorphism may respond to better. So I don't think it's quite ready for prime time. There are some other mutations of interest out there, probably the second most common being the TM6SF2, but less is known about that. And I think one of the other important things is in relation to cardiovascular risk is that NAFL was sort of one spectrum of this whole metabolic syndrome, and that we know that the most common cause of mortality in patients with NAFL actually is not related to the liver, but it's actually cardiovascular disease. And so we think they, in a lot of cases, share a genetic risk, and that PNPLA3 polymorphism has been associated with earlier onset cardiovascular disease.
Yeah, there does seem to be some inverse relationship with regard to TM6 between risk, what type of TM6 SNP the patient may have, and their relative risk for fatty liver disease versus cardiovascular disease as being dominant. But those two are probably the best studied, PNP and TM6, and both seem to govern small fat droplet metabolism in the liver and your propensity to store fat. And it seems likely, but unproven, but likely that in ancient times, these polymorphisms, if we were in a situation of scarce food, when you found food, you could store it rapidly in the liver and then mobilize it out. And so it may have been an advantage in ancient times. Now, when there's an abundance of food, this becomes detrimental in terms of storing too much fat. And not everybody has these, but these are the most common associations genetically. Cryptogenic cirrhosis is cirrhosis of unknown cause, and in general, I think of it as being four main possibilities, and possibly some others, but in general, I think we can all think of it as four main possibilities, those being occult NASH that had not been recognized for years, and then loses the histological hallmark on a biopsy as cirrhosis develops. And that would be things like steatosis and cellular ballooning. Those go away as cirrhosis develops and progresses. So NASH, occult alcohol has been implicated, silent autoimmune hepatitis has been implicated. And then the fourth category is occult virus, and that maybe hasn't been yet identified. When you look at risk profiles in patients with cryptogenic cirrhosis, meaning you've done a biopsy and you've done serologic workup and nothing points clearly to a cause, then you look at their risk history, and by far the majority share the risk factors for NASH, obesity, dyslipidemia, and diabetes. And for that reason, most of us feel that the vast majority of cryptogenic cirrhosis is previously unrecognized NASH, because we know that NASH can be silent for years and then become evident with complications of portal hypertension. And one of the things that I look back at in someone who newly referred in and that appears to be cryptogenic cirrhosis is what was their past history, how long have they been obese, and we look at the platelets. And often you'll see that the platelets have been low for 5 or 10 years, and it's been labeled ITP, or idiopathic thrombocytopenia, and really not evaluated further. But that's a clue that the process that led to the cirrhosis has been brewing for years, then becomes evident as a complication of portal hypertension. Do you want to add anything, Brett?
Yeah, no, I mean, I think, Steve's an expert in this sort of area. And I think these days, a lot of us now in the hepatology world are less apt to label people truly cryptogenic, now that we have better emerging diagnostic capabilities and sort of have, as Steve said, sort of better understand the risk profile of these patients, and that, a good portion of, 70-80% of these can sometimes be attributed to cryptogenic, essentially NASH, that sort of has quote unquote burned out at that point.
Right. There are histologic features. If you go so far as biopsy, there's been histologic features of autoimmunity have been described. That's not very common though, but if you see, for example, plasma cells in the fibrous bands and things of that sort, those have been taken to indicate maybe this patient had an indolent autoimmune process that was silent clinically, and then presents with cirrhosis. But by and large, most of these patients have a risk profile that indicates NASH as being the cause. And frequently I'll identify this as cryptogenic parentheses, probably NASH in parentheses, and we go with that diagnosis.
Yeah, I think just to sort of add a final point, I think one of the other things that we've seen over time is that in patients labeled cryptogenic cirrhosis, if they receive a liver transplant, and then you look back in the patients that develop NAFLD or NASH post-transplant that receive cryptogenic, there's a high likelihood that they originally did really have NAFLD or NASH, since it has sort of occurred in a short time frame post-transplant.
Yeah,
like we see in patients that we know have NAFLD or NASH going into the transplant. Yeah, I think that's a great question. And I think was sort of the impetus for us writing this article here was, as we talked about, NAFLD and NASH are just so common that it's often hard for clinicians to sort of understand the full picture and full spectrum and how to best evaluate it. I think one of the things that a lot of times first brings patients to the attention of a hepatologist is a primary care doctor obtaining routine labs on their physical exam, their annual physical. And one of the things that tends to pique interest is when liver enzymes become elevated. And obviously that can be for a number of different reasons, but a lot of people know that liver enzyme elevations, and oftentimes when I'm talking about this, most often we're referring to the transaminases, so AST, ALT, and less so to the alkaline phosphatase or bilirubin. But when those become elevated, that often starts us down this whole pathway to trying to figure out why the patient's transaminases are elevated. One of the things we know, though, over decades of study, though, is that elevations of these transaminases in patients with NAFLD do not necessarily always correlate well with histologic findings. And so, simply following a trend over time is not necessarily that helpful in a silo, and that these transaminases can be normal in patients with significant fibrosis, and so it should not provide necessarily reassurance. I will say that they are part of several non-invasive composite measures, such as the NAFLD fibrosis score or FIB4 or the APRI, but by themselves, they're not overly helpful, and so we sort of have to take them in the context of the patient. I think one of the other things, and so that sort of starts us on this pathway of labs that what Steve and I like to call can be abnormally normal in these patients. Right. Some of the other things we often see are patients with a creatinine that appears to be normal, and so right when we talk about creatinine, creatinine is often, made in the liver and then stored in muscle. And unfortunately, as people's liver disease progress, they tend to become sarcopenic. So they lose muscle mass and they essentially are losing creatinine. And so over time, really that creatinine level should start to decrease. But in these patients, it often tends to sort of stay stable or actually rise slowly over time. And that can be somewhat falsely reassuring if it's labeled in the normal range, but this patient has experienced quite a bit of muscle mass loss. And so that GFR, or glomerular filtration rate, tends to sort of overestimate what this patient's renal function is.
Some other examples that we cited in the paper of normally abnormal or abnormally normal labs include things like a mild elevation of ferritin, and particularly in NASH. And we often get referrals where the referring provider has diagnosed them with hemochromatosis based on that. But that mild elevation of ferritin is often part of the inflammatory response with fatty liver disease. Another example is often these patients will have macrocytosis, and they end up getting B12 and folate levels. And B12 though will be spuriously high and look normal or look like they have plenty of B12, when actually, if you measure methylmalonic acid or some metabolite of B12, you can see deficiency in some of these patients. So that's one that's abnormally normal. Another example is in a cirrhotic patient when you think they should have hypersplenism and low platelets, but you see the platelets are fairly normal. Sometimes that can indicate be a marker for iron deficiency, where you get a thrombocytosis. And so that would be one where it's abnormally normal and may warrant looking further.
Yeah, and I think sort of add one more kind of key one that oftentimes we get from referring providers are autoantibody positivity, right? And so, when we're seeing patients with elevated liver enzymes, one of the things that often gets measured are markers of autoimmunization. And so an ANA or anti-nuclear antibody, and then often an anti-smooth muscle antibody, or sort of a subset is the anti-actin muscle antibody. And so those can be positive, especially the ANA in up to 20 to 25% of patients with NAFLD. And it's sort of more of just an epiphenomenal finding we see, and that anti-smooth muscle can be seen in about 3 to 6% of patients. So, when we see those, we sort of have to take in the whole context of the patient. So we have to make sure that, is this someone that is at higher risk for an autoimmune disease? So are they, we'll take into account their gender, sort of their history, do they have metabolic risk factors? Do they have an elevated IgG, which tends to be elevated in isolation more in autoimmune hepatitis compared to either an IgA or sort of pan immunoglobulin elevation in NASH or NAFLD. And so if there really is a unclear picture, then sometimes that's where a liver biopsy can come into play. But I think people just need to know that these autoantibodies by themselves are not necessarily diagnostic of autoimmune hepatitis, and simply can be seen in other conditions like NAFLD.
Those are examples of what we were meaning when we referred to abnormally normal in a liver disease patient, or normally abnormal, and not to be too concerned about it unnecessarily. So they're just tricks from a clinical perspective to be aware, for people to be aware of.
And I think just to sort of kind of finish that off, and I think one of the reasons that we also wanted to sort of highlight these normally abnormal and abnormally normal is just to prevent patients from being harmed, and so the therapy and treatment for NAFLD or NASH is very different than that, for example, hemochromatosis or autoimmune hepatitis, where immunosuppression is often the backbone and can potentially be lifelong. And so we've seen examples where patients were treated with these for a while, and may not certainly were not necessarily the correct treatment, and also may have had some adverse effects to their overall clinical course.
Yeah.
So we sort of hope that, your readers enjoy the article certainly, but also sort of are able to take home some pearls and kind of apply it to their clinical practice. And so that ultimately we can kind of take better care of patients overall.
Yeah.